neurodegenerative disorder. And by using the Drosophila flight model system, she did some pioneer study on the molecular mechanism of LRRK2 mutations. And she is also interested in the study of gut-brain axis in Parkinson's disease. And her topic today is genetic and clinical spectrum of Parkinson's disease in Taiwan. Let's welcome Professor Lin.
I would like to thank Professor Shen's kind introduction, and I would also like to thank Professor Lee and the organization committee for having me in this conference. And first, I would like to express my greetings to all the friends in the Asian Ocean Pacific regions online. Today, I'm going to talk about the genetic and clinical spectrum of Parkinson's disease in Taiwan. And as we all knew that the global is aging, and in this age society, I think the number of people suffering from neurodegenerative disorders, especially Alzheimer's disease and Parkinson's disease, is largely increased. So the Parkinson's disease, the second most common neurodegenerative disorder, is my topic today. I think everyone knew about the pathological hallmark of Parkinson's disease starts from the progressive accumulation of the Lewy body in the dopaminergic neurons. And because of the Lewy body accumulation in the neurons, it will cause the progressive deficiency of the dopamine. And then it will affect the downstream basal ganglia and frontal motor circuit control. So at that time, people will start to present with the classical motor symptoms of Parkinson's disease, especially the progressive bradykinase cell rigidity, and at the end, will loss of the posture reflex. However, in the past 10 years, I think everyone knows, and actually we have another talk about the gut-brain axis tomorrow in the movement disorder sections. The Lewy body actually will start from the peripheral systems, especially the gut and anterior nervous system, according to the Braak pathology staging. And the Lewy body in the anterior nervous system will follow the vagus nerve and then enter to the lower part of the brainstem, and finally will affect the dopaminergic neurons. And at that time, people will start to have the classical motor symptoms. However, the Lewy body will not stop in the midbrain dopaminergic neurons. It actually will project through a specific trajectory from the frontal motor cortex to the parietal and the occipital cortex. And I think that is very interesting because everyone wants to know why the Lewy body will follow this specific kind of trajectory. So because of pathology findings, if we think carefully about the people's presentation, we can find that many patients, they will have variable premotor symptoms, especially the gastrointestinal constipation. And then when they start to present with the classical slow motor movements, as the disease progresses, there's not only motor symptom progressions, but also the cognitive function progression, because the Lewy body will also affect the neocortex. So it is a quite suffering long process, because people with Parkinson's disease, they will not only present with the motor symptoms, they will also have a lot of non-motor symptoms, either the premotor symptoms or at the end, the PD with the dementia. However, although we have a lot of new medications, either the long-acting L-DOPA or dopamine agonist, that we can efficiently and symptomatically can improve the motor symptoms of PD patients. Or we can have the very new kinds of new generation of deep brain stimulation that can improve the motor symptoms. But we knew that there is no any neuroprotective therapy that can slow down or even to stop the disease progression, especially Lewy body in the PD patient brains. So I think for patients with Parkinson's disease, the most one of the most important unmet needs for PD is we need to identify or to know more clearly about the pathogenic mechanism of this disease. Because at the end, we all want to find the mechanism target therapy. And every time when I talk about this slide, I'm also thinking about, is there any kind of new medication to truly come out to the market that can really stop the disease progression? And luckily, 2 years ago, there is LRRK2 kinase inhibitor that already complete the phase 1 and enter the phase 2 studies that can slow down the disease progression. So there's truly updated progress of the mechanism target therapy for patients with Parkinson's disease. So let's get back to the pathophysiology of the Parkinson's disease. So just like other complex disorders, it comes from the interaction between the genetic and environmental risk factors and combined with the agent that can speed up the disease onset. So while the genetic play an important role in the etiology of Parkinson's disease, that is because there is around 10 to 15% of patients that either have the early onset of the disease, as early as the 18 to 20 years old of age, or many of them have so-called positive family history, either autosomal dominant or autosomal recessive inheritance of this disease. So I usually like to start with this slide. Like, why do we study genetics, especially in this kind of late onset neurodegenerative disorders? The first reason is because we face the patients day by day. And if they have kind of family history of they are young onset cases, we need to provide molecular diagnosis for the patient, for the family, because they all want to have their children as the next generation. We need to provide the genetic counseling. And the second reason is, as I think that is the most important, is I want to illuminate the molecular mechanism of the disease, because in the future, when I get aged, I want to have kind of mechanism target therapy to slow down the disease progression. And luckily, because of the advent of the recent genetic progress, we have many powerful genetic techniques that can help us to identify the genetic cause of Parkinson's disease. In the several years ago, if we have a large family with familial Parkinson's disease, we can use the family-based linkage studies to narrow down to identify the new causative genes. Or on the other hand, of the landscape for the patients with the sporadic Parkinson's disease, we can use the GWAS studies that to compare the genetic risk polymorphisms between the normal population and the people with Parkinson's disease. And then we can find a specific region of the risk polymorphisms on a specific region of the chromosome and to narrow down which kind of gene can be identified with this specific region. And now, because we have the whole exome sequencing and the whole genome sequencing, because the cost is still high, but in the future, and even now, the whole exome sequencing is cost down compared to the cost several years ago. So we are now have more and more chances that we can find novel causative genes for Parkinson's disease. So this is a very busy slide, but I just want to show that starting from the very first gene identified for familial Parkinson's disease, which is the SNCA gene encoded alpha-synuclein in 1997, till now, 25 years have passed, and there are more than 25 genes have been identified to cause familial Parkinson's disease. So this table will be more clear that since the 1997 till now, especially in the past 1 year, I think because of the pandemic, many PI can have time to write down their manuscript. So in the past 1 year, there are more 5 lane genes have been identified to cause familial Parkinson's disease. So if you look at this table, we can find that half of the PD causative genes can contribute to autosomal dominant familial Parkinson's disease. For example, the SNCA gene encoded the hyperphosphorylated alpha-synuclein, and half of the genes can contribute to the autosomal recessive familial Parkinson's disease. If we look carefully about the protein functions of these PD causative genes, we can find that the alpha-synuclein per se is a kind of synaptic protein that can help neuron and neurotransmission. In addition to alpha-synuclein, there are many other genes related to the ubiquitin proteasome degradation system or another protein degradation system in the cells, which is involved in the autophagosome and the lysosome pathways. And the many genes are related to mitochondrial functions or the Golgi ER trafficking system. So if we base on these genetic puzzles and we put together, we can find that maybe specifically in the very early first neuron get involved in the PD process, there are potentially these 4 biological pathways get disturbed and then impaired the alpha-synuclein protein quality control. So the synuclein will start to get or be more prone to aggregate as a kind of first Lewy body in the neurons. So this is a world map, and we are all in the Asian Pacific regions. And there is a global non-profit organization called Parkinson Foundation actually have select or to evaluate that many centers can fulfill the criteria for Parkinson's disease of Center of Excellence. Means that this center can provide not only the medical or surgical treatment for Parkinson's disease, but also can provide the molecular genetic diagnosis or the whole person care for patients with PD. And there are 2 centers of excellence of Parkinson's disease in Asian Ocean Pacific region. One is in Singapore, which was led by Dr. E.K. Tang, and another one is in Taiwan. So we are lucky to earn the credit of the Center of Excellence. So in the past 15 years, starting from my mentor, Professor Remy Wu, and I and Dr. Dai, we work together that we have lots of early onset familial cases that have regular follow-up in our center. So about 5 years ago, we have established a standardized pipeline for patients with early onset or familial Parkinson's disease. The first part is we will combine the gene dosage assay using the MLPA or the NGS next generation sequencing targeted panel covering 95 genes, including the genes for familial Parkinson's disease or for familial dementia or for familial motor neuron disease. Because we all knew that some people, they are very suffering because they will combine several different kinds of neurodegenerative disorders. And then in this case, we can find this specific family or this specific index early onset cases if they have any kind of non-gene mutations. However, if we failed and there is a large family that are eager to know the molecular diagnosis of their family, we can go for the whole exome or whole genome sequencing. Potentially, we can have a chance to identify the novel PD recessive gene. And in this case, if we do really find kind of novel variant for the disease, for the families, we usually need to perform the functional assay using the in vitro or in vivo model systems to prove its pathogenicity. So here is a brief summary that in the past 10 years, we have collected numerous, around 300 sporadic early onset cases and around 100 or 150 more about the familial families with Parkinson's disease. And as we can see from the summary figures, that if people who have early onset cases, and they also have autosomal recessive family history, like the family pedigrees show here, that siblings are all affected, but their parents are healthy. In this case, there is 10% of this kind of family, they will carry the Parkin mutation. However, if they don't have family history and they are only sporadic early onset cases, the mutation frequency will drop to around 5%. And for the phenotype of Parkin mutation carriers, the onset age is very young as 15 years old, around in the age of the senior high school or in a college student. And I don't have much time to talk about detail about the Parkin genetic mutation carriers. I think the Japanese friends will be more familiar with the phenotype of Parkin carriers because they usually will have the onset of the foot dystonia, have the diurnal change, and they will also have very excellent responses to L-DOPA. But they will also have a lot of non-motor symptoms, especially the depression and anxiety. So when we encounter people with Parkin mutation, that we need to take care not only their motor symptoms, but their also non-motor symptoms. Second, in the mutation phenotype, in the mutation type, in our cases, most of the mutations, half of the mutations are actually kind of deletions, especially a large deletion covering from exon 2 to exon 5. So in this case, if we only use the single sequencing or the NGS targeted panel, that is not enough because we may miss this kind of large deletion. So that's why we will miss the MLPA deletion assay for the patient with early onset cases. Now we change the gear to the autosomal dominant families. And in this case, actually we feel a little bit frustrated because we only identified around 10% of cases that we can identify their molecular genetic diagnosis. And among these known genes, the most common mutation contributing to autosomal dominant families is the leucine-rich repeat kinase mutation. And leucine-rich repeat kinase mutation is very famous because it has a mutation hotspot in Western population. But the mutation hotspot is the G29S mutation, which is very popular in Spanish Jewish population. The mutation rate is as high as 40% in familial Parkinson cases. And even for sporadic Parkinson disease, there's around 30% that can carry this mutation. However, in our region, we rarely have the G29S mutation. But it does not mean that LUG2 is not important in our vicinity, because we do really find another mutation, such as they show in this slide that there are many mutations are actually identified in our screening. And they are also in very important domain of the LUG2 protein. For example, the I2012T mutation is very close to the Western population mutation hotspot G29S, which is also located on the kinase domain of the LUG2 protein. And another mutations are located in another important GTPase RAS domain in this protein. So the same gene, but has different mutation hotspots in Western and Asian population, but they also contribute important roles in familial Parkinson disease. In addition to LUG2, another gene I want to highlight is SCA mutations. SCA, we know that the clinical presentation is usually a progressive ataxia, but based on I think it's 2000 paper published by Professor Shen, that he identified that the borderline repeat of the SCA2 and the SCA3 can present with pure Parkinsonian feature. So in our population, if we encounter patients with autosomal dominant Parkinson disease, we should screen the trinucleotide repeat mutation, especially SCA2 and SCA3, and sometimes SCA17, if the patient also combined with some kind of cognitive decline or seizures. In these cases, the SCA17 will be positive. So because we really do a lot of efforts, want to identify the molecular genetics of these families. However, as I just mentioned, I feel frustrated because there are still many families, they don't have their molecular diagnosis. And just like they showed, like we have a lot of these kind of families in our hands. They are eager to know whether they have kind of mutation because they want to consider whether there is a genetic counseling for their next generation for these young kids. So it's our responsibility for us to identify potentially molecular genetic diagnosis for them. So because we have these families which have been screened for non-mutations, but the result is negative. So we go for the whole exome sequencing, and now we can go for the whole genome sequencing. So this family is just an example that, as we can see, is apparently an autosomal dominant family inheritance. The clinical presentation is just like the sporadic Parkinson's disease, except their onset age is a little bit earlier, around 40 to 55. But the presentation is tremor predominant and L-DOPA responsive Parkinsonian features. And the trodate is very typical to the sporadic PD patients. They have the half loss of the dopamine transporter on the trodate. However, our young doctors are really very smart and very considerate when they're taking care of the patients. Because when the proband admitted to the hospital, they found that there are some kind of difference in these patients. We notice that there are some kind of intrinsic muscle atrophy and decreased deep tendon reflex of these affected members. So we performed the nerve conduction study and we find that all the affected probants or the affected family members who have Parkinson's disease, they also have mild sensory and motor axonal type polyneuropathy as well. So we called all the family members to the study room and perform all the neurological examination and nerve conduction studies, and we found this kind of phenotype actually go together. So this is a very interesting family because the phenotype is very unique. They present with a central dopaminergic neuron degeneration, but also they present with a peripheral sensory motor polyneuropathy presentation. So based on this family, we go for the NGS panel for the non-targeted genes. Of course, the answer is negative. So we perform the whole exome sequencing from the 3 affected members and 1 unaffected member from these families. And to cut the long story to be short, we identify 1 potential pathogenic variant in this UQCRC1 gene. And then in this case, we want to prove from the clinical part whether this novel gene is really truly a novel gene for familial Parkinson's disease. But as I just described that we are in a very small island, so the collaboration is very important. So in this case, we collaborate with our Japanese colleagues in Juntendo University Hospital and our colleagues in the Seoul University Hospital. We totally have nearly 700 PD families and around 2,000 sporadic PD cases and 1,000 control participants that we want to screening whether the UQCRC1 can have another mutation in other affinities. And luckily, we find another 2 families which also carry the UQCRC1 potentially pathogenic variant. And for this 3rd one, which is a Japanese family, it is a friendship mutation around the axon and intron junction. So we perform the CDN analysis and we found it really affect is splicing and coated a truncated form of the protein. So what is the UQCRC1? It actually is a co-protein of the mitochondria respiratory chain complex. And mitochondria, as just I mentioned, is a very important contributor to the PD pathogenesis. And there are many complexes in the respiratory chain. But before, we only focus on the complex 1 because for the rotenol or for the pesticide, they are all complex 1 toxin that can cause the progressive dopaminergic neuron loss. However, in this respiratory chain, not only the complex 1 disorder can cause the free radical increase, complex 3 also can contribute to the ROS free radical production. So there are 2 years ago, the protein structure of the complex 3 was dissolved. And it is a dimer, and there are 2 important co-proteins for the for the respiratory chain complex 3. One is our target, UQCRC1, and another one is the UQCRC2. They are dimer together. So we look back to our identified 3 mutations. They are all species conserved across species. And if we use the protein modeling elimination, and we found even the carry missense variant, they will change the important domain of this protein because it is a dimer. They need to combine together to work functionally. So in this case, we go for to check its pathogeneticity through the functional assay. So we use the CRISPR-Cas9 knock-in model to establish the knock-in cell and knock-in fly and knock-in mouse model system. So for the cells, we choose the clone that have the similar protein expression level of the mutant clone to compare their phenotype and to explore their function. So as we can see from the lower panel, they are the knock-in cells compared to the control. We can find the neural length is shortened compared to the control, or those wild type will also perform the CRISPR-Cas9 techniques, but it still remains the wild type. So it's another important control for this kind of functional assay. So in this case, we found that neural length is decreased, which is a kind of sign of neurodegeneration. And then using this cellular model system, we're using the seahorse assay to measure the respiratory function and the ATP production. And we found in these mutant cells, which carry the human mutations, they all present with decreased mitochondrial function and ATP production. And consistently for these mutant cells, they also present with increased free radical level, which is not surprising because it is a mitochondria mutation, mitochondria component mutation. So we then look carefully whether the complex 3 specifically really impaired by this mutation. So again, using the seahorse assay, we found that when the cells carrying the specific mutation from our index family, the cells do really have decreased the complex 3 activity compared to the other complex. So it specifically impaired the complex 3 activity in these mutant cells. So then we move on to the in vivo model systems. So in the fly model systems and in the mouse model systems, we also see the same phenotype that they have the age-dependent locomotor defect. So from this mouse model study, if we're using the open field assay, we find that these mutant mice will present with the locomotor defect compared to the age-matched lead control. And if we intraperitoneal injection of the L-DOPA, they can largely rescue the locomotor function defect. So it means that the locomotor function dysfunction is largely caused by the dopamine insufficiency because the locomotor function can be rescued by L-DOPA. So then we use the following 3 methods to demonstrate that there is truly dopaminergic neural loss in these mutant mice. The first one is the micro-PET with the flow dopa PET. Compared to lead control, the mutant mice has a decreased dopaminergic neurons in the substantial nigra. And using the HPLC analysis, the dopamine level and the turnover rate is also decreased. And from the histocytology analysis, the upper panel is the lead control. The lower panel is the mutant mice. They also show the age-dependent progressive tyrosine hydroxylase positive neuronal loss in these mutant mice. So in this case, the next question we want to ask, whether this mutation, which is on the mitochondrial protein, is this specifically impact the dopaminergic neurons or other neuron systems are affected or not? Actually, we do really see the Purkinje cells of the hippocampus. There is a hippocampal neuronal loss in these mutant mice, but there's no any influences on the cerebellum. But for the peripheral nervous systems, the mutant mice also present with the human phenotypes, that they have the decreased the nerve conduction study, and for the sciatic nerve studies, they also show there is a peripheral nerve degenerations. And finally, we look carefully about the ultrastructure using the electron microscope. The left panel is the legitimate control, and the right panel is the mutant mice. As we can see from a single dopaminergic neurons, the mitochondria of the legitimate control is a double crystal, a very beautiful structure. However, in the mutant dopaminergic neurons, there is a fragmented and valculated mitochondria, which is a very strong evidence to show that in these mutant mice, the mitochondrial structure is impaired. So based on our study, we demonstrate that there is a novel mutation, although the phenotype is very unique, but we use the in vitro and vivo model systems to demonstrate its pathogenicity. So again, we find another evidence contributing to these puzzles that mitochondrial pathway is also important for Parkinson's disease. So this is my final slide. In our population, we do have a lot of mutations, but the mutation hotspot is different with the Western population. And for the UQCI mutation, which is quite rare because the phenotype is unique, it combined with the peripheral neuropathy as well. So in the future, if we look for the patients, we should very carefully to do the neurological examination to see if there is any signs of peripheral neuropathy. So I would like to thank all my colleagues in my institute, especially the NTUH and the NTU, the College of Medicine. All the study works were done in our campus. So thank you for your attention. Your comment is highly welcome. Thank you.
Congratulations, Professor Lin for identifying a novel gene responsible for Parkinson's disease. Any questions from the audience? Well, we know that there are many genes involving the mitochondrial pathway. And are there any difference in the phenotype expression of these different genes causing the Parkinsonism? And what's the possible mechanism? Because I think the all cells need energy.